All right, so I'm going to talk about living kidney donation and giving the gift of life, but this is a focus also on a very special group of patients that have what's called nutcracker syndrome, and it'll also be a comprehensive review of what renal vein compression is. I've given this talk recently, and some of my coordinators say that I went through it too fast, so this is their second shot at it. Beth? My disclosures are I am a member of the OPTN board currently. This talk has nothing to do with those responsibilities. The other disclosure, which I say to patients on first meeting them, specifically the nutcracker patients, is I'm a transplant surgeon. They're coming to me because I fell into this, and I'll tell you the story, but it's your kidney. Do what you want with it. We believe that you have the disease, and we're here to help you. And that's how I opened the conversation, because this was not a bait and switch or anything else for taking your kidney. It is simply, it's a underdiagnosed, and it's like fibromyalgia or Lyme's disease. People go through a lot to get to actually having the diagnosis and having it treated. So first, to living donation, why all this matters of what we're doing today. There's over 90,000 people waiting for kidneys right now based on the UNOS registry. Living donation can shorten that wait time, and you've heard some stories, and there's more to come, from years to months. And it also, there's a double win, is that living donor also takes one kidney more from a deceased donor for someone else, because that person comes off the list waiting for a kidney. So it's a double win. So Nutcracker is a triple win in that context. But this just demonstrates the wait list versus the living donors as of 2024. And then the key, which has been stated over and over, is the goal is to do no harm. Yes, there's an operation involved, but to maintain the normal quality of life with one kidney. At lunch, I was asked about how we know this and all, and young and pregnancy and all these other things. And essentially this has been going on now for 60 years. The first real successful kidney transplant was a identical twin at the Brigham and Women's. Dr. Murray received one of 6 Nobel Prizes to surgeons for medicine for that accomplishment. He was a plastic surgeon who did it. So there's a connection between transplanters and plastic surgery. But anyway, the brother who donated lived for an additional 50 years. And what we know is with Veterans Day just having passed, and thank you for those who have served, we know from those who have been injured and lost one kidney, they live completely normal lives afterwards. In addition, if you do donate, and I had the privilege of doing this, the system is built so that when your one kidney fails because you donate, you go immediately to the top of the deceased donor list. So it's not like you're hurting yourself.
Out of your face. Oh, no, no, please, you sound good that way. I want this out of your face.
Okay, thank you. So we know that it's safe for all ages. There are large databases that prove that. Sometimes there's a little hypertension or albuminuria, but we monitor it. As John said, there are regulatory things out to 2 years, but we're available as a transplant center. If you've operated on someone as a surgeon, you always feel responsible to them, even if not. So there are set regulatory time points at 6 months, a year, 2 years with checking and all that, but we're still there. As far as living donor milestones, that it doesn't project well on this, but up there it's okay. Those are the time points where we're required to see the patient. And what we do know is a living donor kidney works better than a deceased donor kidney. My analogy for patients when talking about kidneys and for them to look for living donors is, a living donor is like a Formula One, NASCAR, Lamborghini, whatever. I use cars as the analogy. A deceased donor, standard criteria, is like a brand new car, a Chevy, a Toyota, a Ford. Then we have extended criteria. Those are like used cars. All of them get you off dialysis. It's just a matter of how long, and we try as healthcare professionals to match. We're not going to give a used car to a pediatric patient because then it sensitizes them and all. We're going to wait for the Lamborghini. But that's part of matching it and all, but that's part of educating patients. Now on to Nutcracker syndrome, and it's also called Nutcracker vein anomaly or left renal vein entrapment syndrome. My first case was 10 years ago. It was a 22-year-old female. I was in Charleston, South Carolina. She had truly debilitating abdominal pain that she could not continue in college. She had previously, as a teenager at an esteemed institution, had a renal vein transposition where they moved the vein that's trapped down farther in the vena cava at age 16. It worked for about 6 or 7 years. She elected to come to us in Charleston. She wanted to get rid of her demon kidney, and so she had a lap donor nephrectomy. When she woke up, the symptoms were gone. She went back to school. She's stayed in touch, sent me pictures of her babies and everything else, and so she's 10 years out doing very well. This is her demon kidney. For all my donors, I give them a picture of the kidney. Some come with creative art. Others tell me what they want written on the card. The third is I just write my kidney. You met Matilda earlier. This is the meeting of the donor and the recipient in-house on post-op day 1. And this is my coordinator at the time and our celebrating that event in front of a bell, which honors the donors and all that we had in Charleston. So what causes this Nutcracker syndrome? It's essentially anatomically, we all have what's called a superior mesenteric artery. The vein crosses under it. Many of us have enough adipose tissue to make it so that that artery doesn't compress it. This is very often in thin people. It was first described in 1937, and it basically is like a vein being squeezed between two vice grips. This is all the history, and like I said, I'd get through 72 and 22 or 20. So these are all the landmarks of describing this. Truly, Nutcracker syndrome is different than just having Nutcracker vein anomaly. It requires a constellation of abdominal symptoms or other symptoms along with the radiographic finding. There is also a variant where the vein goes underneath the aorta, which is the big blood vessel that comes from the heart, that can cause that compression as well. Graphically, this is what it's showing, demonstrating where that artery with the vein that crosses over, it causes dilatation and swelling of the vein because of diminished outflow. So it's like a beaver in a dam. The beaver builds their dam, and suddenly you swell, you end up with lakes or otherwise, or when it's man-made Hoover Dam, we interrupt the Colorado River and have Hoover Dam and can do electricity and all these other great man-made, but this is anatomically, Nutcracker is the same as this, with the backing up of the water behind it, but in this case it's blood. On X-ray, what you can see is this is a normal CAT scan. What you see with the arrows, is my mouse moving up there? No. All right, so what you see up in your left hand is the superior mesenteric artery. The area below is, you can see, this is the vein coming off, and you can see it cross over. And then when we look at it this way, you can see where the arrow is, it compresses it. It makes it less, very thin, so all that blood, which is half of your blood volume, which needs to get back to your heart, has to get there another way. So radiographically, there are certain criteria in the literature. Essentially, this is looking at it cross-sectional. If you cut me this way, and what you see is that artery is compressing that vein, which is the blue structure up there. Sometimes it also can compress the intestine. That's called SMAS syndrome. But basically, it pinches it, and therefore causes a backup of the blood and then causes the symptoms. So these are just the other criteria. You can see radiographically on a CAT scan how that is, showing it in the two different ways. So the other way of diagnosing it is they put a catheter into your vein, and you can see all these extra vessels going there and with the compression, as you can see up there. So the other way I said is a retroaortic, where the vein goes underneath the artery. And you can see how where it's between the aorta and the vertebral body, and there's a pinching again. The blood flow, this is just to show how it migrates. It goes down. Associated with this can be what's called pelvic congestion syndrome, which is all the vessels in the pelvic area are swollen. It can accentuate what's called May-Turner, which is another compression of the iliac vein. All these cause symptoms like bladder irritation, difficulty having bowel movements, painful intercourse, and then there's a whole other constellation which I'll show you. This shows you, for those who want to look graphically, you can see where the arrows are. Those are all the extra veins that are there naturally but aren't dilated normally, but are dilated because the blood's getting back to your heart a different way. Normally it would be just where the arrows are crossing, that would be the normal gonadal vein, but then you have all these extra collaterals that develop. So it's a diagnosis of exclusion, like I said. So these patients suffer for years to get there. Very often they present multiple times to the ER with unrelenting abdominal pain. Usually it's a gallbladder, it's got to be irritable bowel, endometriosis, all these things. But this is a whole list of things that they will present with, including hematuria, all those GI symptoms. I've had some patients have continuous brain fog or migraines. They have terrible back pain or sinus congestion, as well as the other symptoms. This just graphically shows it in a different way. It can present in men. It's more predominant in women, but it can be as a varicocele or testicular pain. Out of the over 100 I've seen, I've had one male. Associated with these compressions are one which is called MALS, which is a compression of a different artery that's more proximal or higher up on your aorta. I showed you the SMAS. May-Turner is on the iliac, so it ends up with left leg swelling. And then there are other associated syndromes called POTS, Ehlers-Danlos, which is flexible tendons, and mast cell activation. This just demonstrates MALS, which is the higher artery, and how we release it surgically. And we do it as a diagnostic test is by numbing the nerves around it to determine it. May-Turner, you can see with the arrows where the aorta is compressing the vein, because the diameter farther down on the right-hand side is the normal diameter of the vein versus where it's compressed. The usual workup when these patients come is essentially most of the tests we need for them to be a living donor. They all have normal lab work. Most of them, because it's nonspecific, have been worked up for Lyme's disease. Almost every one of these patients that I talk to has had an upper endoscopy, a lower endoscopy. They may or may not have celiac, may or may not have Crohn's, IBS. They all, since they're mostly women, and have this pelvic congestion very often. They've had ultrasounds, vaginal ultrasounds. Some have undergone hysterectomies. Most of them have had a scope put in for endometriosis. Just about everyone, standard, you go in with abdominal pain, you're going to get a CAT scan. They're going to examine you, but the CAT scan is the current teaching because it's so easy and all, as opposed to when I started medical school. So they all come with a CAT scan. Many radiologists don't pick up on this. And then the venogram that I showed already. So what are the interventions? This is a whole list of different things that are offered out there in the world. They include blocking off the extra blood vessels, to stenting them, to moving the kidney to try to change the angle, to bypassing them. I'll show a couple pictures of them. What at Temple we have to offer after this has followed me, and I'll show you how it has come about. Essentially, we're offering them what they want for their kidney that includes a therapeutic nephrectomy. They can either have an auto transplant, which is basically the same operation of a donor and the recipient all in one operation, or if they want the smaller operation and they are so inclined, they donate. This is the stent for what interventional radiologists or vascular surgeons can offer. It's to try to balloon it up and push that artery above. They work. I don't know how many work or fail because there's no database or repository for all this. I just know the patients that kind of have self-referred themselves to us. And this just shows how it looks radiographically. As far as moving the vein, this graphically shows moving the vein down. And then this is moving the gonadal vein to try to decompress. But as you can see above, the larger vein is still not really decompressed. So very often these don't work. So many of these patients have come. And then this is from a surgeon down in Dallas who is trying to wrap the vein with Gore-Tex to try to protect it from being compressed. So our approach is, for this whole process, it's all self-referral. We're not out there grabbing people and saying, you have nutcracker or whatever else. We see the radiographic things on donors, recipients and all, but unless they have symptoms, not. But they kind of reach out to us. We get all their records. I act as the screening tool just because I've been doing this now for 10 years and talk to them, give them their options, and then they get back to us when they want, which route they want to go. If they want an auto transplant, it's pretty easy. They have symptoms, they have radiographic findings. We'll make sure they'll be okay with the operation, and then we can schedule their operation, and then we follow them. For the transplant, you've heard parts of the whole process. That then becomes separate. So that's where my disclosure comes. I am a transplant surgeon, but I'm not pushing for it. So then they're seen by a different transplant surgeon, one of our transplant nephrologists, living donor advocate, the psychologist, the social worker, the coordinators, everyone else, and we go through the whole thing and present them as a living donor. And then yes, no. I will say one of the patients who really wanted to donate, my astute senior nephrologist picked up on something, did a biopsy, discovered that it was not in her best interest to donate, period, so she elected for the auto transplant. Her symptoms were resolved, but that's us doing our due diligence to protect the patient. And then as a result of doing this and part of that paired exchange, there is a pathway through NKR now where you can go in as a nutcracker patient and say, I want to donate. So with that, we've gotten people from all over the world. We've operated on people from England. We have a couple we're working up now from Croatia, a couple from Canada, and then all over the country. To date, we've seen 103 in the last 3 years. No one has elected just to have their kidney removed. 7 have elected for auto transplant and 18 have gone on to donation. So that means it's a slow, thoughtful process. The person who is suffering this gets to decide when and where and how they want to proceed. And then a couple of them afterwards have had May Turner stenting and 2 Mal's release and 1 lymphocyte drainage. This is one of those artworks of one of the patients. So it just shows how they feel about losing their kidney. And then the patient, what's wonderful and where this is a triple win, 75% wake up and their symptoms are gone. They're suffering from pain from the surgical procedure, but their nutcracker symptoms have been resolved. And then public resources, as I said, NKR has created a nutcracker page. They have 10 centers that are considered centers of excellence for nutcracker. We are one of those. This is just the experience of 3 of those centers on patients. They've had open nephrectomies, right, left, all lefts, laparoscopic or robotic, and all of them had pain relief in a, this is how most of these patients come to me. There's this, it's a closed Facebook group. You can't be a medical professional, and I don't know how they do the screening or whatever, but at least the experience has generated enough positive experience with us that they call us up, and after I give my disclosure, I said, how'd you find us? And it was, well, the Facebook group. I found out, in addition, that there is a association now for this. They have chat rooms. They even have a doctor's directory. I haven't seen the doctor's directory. I assume we're on it. And then they're even a 501c3. So they're tax exempt, trying to help people. Our team, which makes this all happen, you've seen a lot of them, but I have to acknowledge them all, both for making this symposia as making this all work. This is primarily our living donor team. Many of them have already been up on the podium, so I thank you all for all your hard work. my fellow surgeons who are all part of this. This is our psychologist, social worker. You're going to hear from William a little later. You're also going to hear from Kevin later, and then Adam, who's actually minding the clinic right now. And then our 4 transplant nephrologists as well. And then the 3 PAs who take all the initial calls for all these patients or the emails. And then Megan is here. Please stand up. She was a recent nutcracker who came to us from upstate New York, and so she can answer some of the questions of how this program was. I keep you in this talk, Megan, because you were in the Philadelphia Inquirer, but I didn't know you were going to be here. But this is Evelyn, who we also do the transplants at St. Chris, and so she ended up donating to a pediatric patient who is now in college. So her life was transformed as well as Evelyn's. And with that, I am done. One minute to spare. Well done. Well.
Right in time for Christmas, we got the Nutcracker presentation done. Okay, so welcome now, and we will hear more about cell-free DNA.
Sounds great. Thank you. Started. So my name is Hannah Bejerlighty. You did I've never heard my name better pronounced by a stranger than you did today. So, yeah, well. So this is Proactive Transplant Care with donor-derived cell-free DNA. I work with Natera. So today what we're going to talk about is just a little introduction as to who Natera is, talking about the journey of kidney transplant, why monitoring for rejection matters so much, how cell-free DNA testing is part of that new standard of care, patient support throughout your journey, and then also how to talk to your doctor. So a little bit about me. I'm a clinical nurse coordinator here with Natera in the Northeast. I worked for about 9 years in the pediatric intensive care unit. So I would take care of patients right after their transplant and do the hourly urine monitoring and get all excited and do a lot of that. So I loved being on that side of things. I would sometimes have patients with dialysis before transplant as well in the ICU if they needed to be there. But it really got me interested in transplant. So I've been with Natera for about 3.5 years. Most of my time was spent on the West Coast, but I recently relocated back home to the Midwest and started in the Northeast. So here at Natera, our mission, we aim to make personalized genetic testing and diagnostics part of the standard of care to protect health and inform earlier, more targeted interventions that help lead to longer, healthier lives. So this is our founder, Matt Rabinowitz, and he founded Natera because he believes all patients deserve access to technologies that offer early detection of genetic diseases. So since I'm talking about cell-free DNA, and I don't expect that everyone has to know what that is, I'm going to start by just defining cell-free DNA. So you will see it abbreviated a lot, that's cfDNA, but we're talking about cell-free DNA. So it's highly fragmented, double-stranded DNA. Fragmentation patterns often offer clues as to the tissue of origin, and they exist in both healthy and diseased states. So we all have cell-free DNA in our system. It's just when a cell opens, there's some leakage of DNA, and we have that circulating in our system. So it's generated from cellular apoptosis, necrosis, and secretions. You have it in various bodily fluids, so plasma, urine, CSF fluid, and it has a really short half-life, which is key just because it gives an in that moment snapshot of exactly what's happening in that 30 to 90 minute window. So Natera has over 10, almost 15 actually, years of experience with cell-free DNA. So even though the Organ Health Department, which is what I'm part of that works with transplant patients, it started in women's health. So first it was really taking fetal versus maternal cell-free DNA. That then they took that technology and went into the oncology space. So then cancer testing, and that used tumor versus cell-free DNA. And then on the bottom, the green, this is organ health. So we have a kidney team, and then we also have a thoracic team, so they do heart and lung transplants. And so we work with cell-free DNA versus donor. So again, quickly, that's the fetal cell-free DNA. That was determining the risk for fetal chromosome abnormalities. Then you have the tumor cell-free DNA, which was used in oncology to help with malignancy, responsive treatment, and early diagnosis of cancer. You have the donor cell-free DNA for our solid organ transplants, kidney, heart, and lung. And then, of course, you have your cell-free DNA circulating, which is what we're comparing to. So I'll talk briefly about the first year of transplant because, again, it's really different based on the patient, based on the provider, based on your hospital. So as was mentioned, I think when Alex was up here, the transition of care piece, that can really happen at different times just based on what your provider does. So in that first couple days, you're going to be in the hospital. You're going to be getting labs all the time. You're going to have your urine output monitored. It's going to be a lot. Eventually, you might go out to your general nephrologist. Maybe you live far away. Maybe that's just how your transplant center does that. Or, as she said, maybe you'll stay a patient of that transplant center for longer. But eventually, the point is that, as mentioned before, your meds and your labs really start to space out over time. So initially, they're quite frequent, and then you'll get out to maybe every 6 months or every 1 year. So we want to manage medications and side effects to avoid infection, the possibility of the disease coming back, and of course, rejection. So signs and symptoms of kidney rejection. Some of you may be very familiar with this list, but fever, flu-like symptoms, tenderness or pain over the area of kidney transplant, swelling in your hands or feet, rapid weight gain of several pounds in a 24-hour period, an increase in blood pressure, increase in creatinine, or a decrease in urine output. So it's important to monitor for active kidney rejection because we know that 2 to 3 out of every 10 kidney transplants fail within 5 years and 1 out of 2 in 10 years. And of course, there are tons of other factors involved with that number. But transplant patients may develop complications after surgery weeks, months, or years later, one of which is active rejection. So active rejection occurs when your immune system does not recognize that transplanted kidney and attacks it. It thinks it's a foreign object. There are different types of rejection, and there are, of course, different treatments that go along with that. So I want to talk about this toolkit because the standard of care for kidney rejection monitoring, we believe now includes cell-free DNA. So everyone's familiar with serum creatinine. This checks how well your kidneys are working, but it might not be quite as fast or catch rejection as quickly. DSA is when your body's defense system sees your new kidneys as something foreign and creates antibodies that for its own protection, but again, that's maybe not an early indicator. Biopsies are necessary. I should make very clear, cell-free DNA is not diagnostic. It's part of this toolkit, just like your other labs, but it is not going to say with certainty whether you are in rejection. So biopsies are very necessary, but in a perfect world, we'd like to limit them, or at least say when there's an indication for one and not just biopsy for no indication. So then cell-free DNA more accurately measures injured cells from your new kidney to talk about the risk of rejection. So again, like I just said, we would love to rule out unnecessary biopsies. So as a valuable rule-out test, again, not diagnostic, a rule-out test, Prospera helps avoid unnecessary biopsies. So if your test is negative, this is giving you greater confidence than any other method that your body's not rejecting. So you can see there that there are 3 times fewer rejections missed with Prospera, which is just the name of our cell-free DNA test. There are others out there when you compare it to serum creatinine alone. So tracking the health of your transplant with confidence. So it's more accurate, cell-free DNA, I should say. It's more accurate than the standard tools such as serum creatinine. It's obviously less invasive than a biopsy because it's just a standard blood test that you would get with your other labs. So it's more comprehensive for detection. We use 2 measurements to help rule out any of the extra reasons why it could be high, which is something I'll get into in a moment. So this is how the test actually works. So you have your blood drawn, you see over here on the left, and the donor cell-free DNA is in the blue. Hopefully the color is yes. So the donor cell-free DNA is in the blue, and the recipient is in the green. So you can see on the top right, you have tons of green with just one little strand of blue, which means there's really so little donor cell-free DNA circulating, it's very dilute, that this for us would be a negative or a decreased risk of rejection because you don't have a ton of circulating donor cell-free DNA. Comparing that to the bottom, there's actually more blue than there is green. So there's a lot of donor cell-free DNA being shed from that kidney. And so this for us would indicate a higher risk of rejection. And again, to be clear, it's not saying 100% you are in rejection. It's just saying there's an increased risk. And so let's add this to the toolkit and let's see if we can find out why. So there are lots of factors that could influence typical cell-free DNA test results. And many of us have some of these on this list. There could just be normal variation. you could maybe have an infection when you get your blood drawn. And so it's increased for a reason other than anything having to do with your kidney. You just happen to have an infection. Age is a factor, surgery, shipment of the actual vial, chemotherapy, maybe a high BMI, heart attack, dialysis. There are many different reasons. So you can see that this is our reporting sheet, and why I think it's so great to show this is because, the doctors will get a copy of this. Your percentages and your fractions are in the top left. On the right, it's going to show you either that orange that you see there would be increased risk, or it will be green for decreased risk. But one of the reasons we would really recommend a baseline lab or some sort of surveillance is because then you can really track the trend. So let's say that you get one cell-free DNA test and it's high. That doesn't necessarily say very much about what's going on, because what can you do with this one high result? So if you had 3 normal results and one spiked really high and then the next goes back down, maybe you just had an infection. Maybe there was something with that sample and you're not trending towards a high result. That's really different than when we get a graph of a patient where each test it's going up and up and up. Or maybe it's been flat all the way along and you know that you just have another tool helping you know that your kidney is doing well. So again, it's part of this toolkit, which I know I keep saying, but it's supposed to be part of the picture. We really want to help make that picture, put all those puzzle pieces together, because these are all things to think about if you did have a high Prospera result or cell-free DNA result. So again, is there variability from baseline? What's your clinical presentation? That's super important. What do your other labs look like? Have you had previous rejection? Do you have an infection right now? This is also a way that maybe your medications could be changed. Do they need to go up? Do they need to go down? Do those need to be looked at and maybe modified to help make sure that we're taking the best care possible of your kidney? So assessing key information throughout your testing process. We do have financial assistance and resources. We take most insurance. Access to test results, if you ever do get a test. This is a bit more specific for my company. I can't speak to others. There are other cell-free DNA companies. But with Natera, if you get Prospera testing, we have a patient portal. So you would be offered that upon signing up for your test, and it's something that you could track your own results. We also have a bunch of videos online. You can go to our website even without taking a test. You could go to our website and see our videos. Depending on how your doctor orders, we can also help with blood draws, but that's entirely up to your specific case and if your doctor orders it that way. And then we have resources along the way. So we work with genetic counselors, MSLs, we have medical directors, I'm a nurse coordinator. We have people in every step so that we can talk to patients, we can talk to providers, we can talk to you and really help throughout that journey. And I don't have to read every single one of these, but we thought these were just some helpful questions just to kind of spark some ideas. So on the left, you'll see just some more generic questions for monitoring rejection that could stem a conversation if you feel like this is something that would be relevant to your case with your provider. And then on the right, it's a bit more specific, obviously, to cell-free DNA or Prospera, but just really thinking through, again, what does a high result mean? Should I get a baseline test, and should we do more surveillance so that watching that trend really is more impactful? So this is my last slide. I'll ask questions, and I'll leave this up for a second just in case anyone wants to take any notes. Yeah, absolutely.
Thank you. What is the percentage of usage of the test, your particular test, when it comes to medication changes versus rejection monitoring?
I'm going to see if anyone on my team here has that specific, because I don't want to throw out a random thing, and we can get back to you. But unless anyone has it specifically at the top of their head, we can follow up with you for sure.
Thank you.
Yeah.
Thank you. Oh, yep.
Patient here saying, I am confused how to use Natera to determine rejection. Isn't this your doctor's call?
Yes. So this is just something I'm presenting and just letting you know that this is a tool out there And that's why I left this last slide up. This would really absolutely be a conversation you're having with your doctor and your team. So this is something that if you feel like you would be a good fit for this, you could ask them. And then you guys can decide together, or your doctor can ultimately decide if it's something they're comfortable ordering, if it's something that they use, if it's something that they would like more information on. But I'm not asking you to go out and try to get this on your own. It would all go through your provider. Go ahead.
To answer it more, you've seen one transplant program, you've seen one transplant program. So this is newer technology that we are embracing more and more to reduce biopsies. And so each program is at different stages of incorporating it as part of the monitoring system.
Leads to the next question from
Yeah.
a different patient on here. These are all great questions. Is this test available for patients who were transplanted before the test was available? I am 27 years post-transplant.
Yes.
Yes.
Yeah.
The short answer is yes.
Yes.
The frequency for a 27-year out
Yeah.
transplant is not the same as, it's more useful in the early period. At 27 years, you and your body have come to a symbiotic relationship or tolerance, as it were. And so the frequency is much less.
Definitely. In the beginning, patients might be getting this once a month, every other month, every 3 months, whatever kind of the protocol with their doctor, and then eventually would maybe be spacing out to maximum, maybe once every year with their other labs if you're that many years out, or whatever protocol your hospital would follow. Yes.
One more question.
Yeah.
You had a slide with various different parameters, and you said all these are important when it comes to determining the risk of rejection,
Yeah.
whether to do biopsy perhaps. Have you incorporated your particular test into an algorithm so that the doctor or the nurse can make that determination versus looking at individual results?
If I so base.
Yes, all the companies are doing that.
Yeah.
They're coming up with analytics to incorporate it with the standard testing we do. And each of the three variations of the test are incorporated in that for both acute prediction as well as long-term outcomes, because we're trying to leverage AI and all those things with the thousands of patients that have done it, plus their other tests.
Thank you.
more-
And speaking about that, I think we're going to move to our next presentation now to talk about innovation in transplant medicines. If we can welcome Dr. Perrin.
So that was a great presentation, and I don't have data like that in my presentation, but we did collect it, and I will honestly say I'm not an investor in any stocks of that company or the other ones. It is the best predictor in our clinical study of rejection of all of the things we looked at. It was the earliest predictor of rejection, cell-free DNA. It's a great tool.
Great endorsement.
Thank you for inviting me today. My only disclosure is I'm an employee and also a board member at Eledon Pharmaceuticals. So this slide has a lot of busyness on it, but I kind of kept it up here because it really encompasses who we are as a company and what we're achieving to accomplish. We're developing an antibody that's called tegoprubart. It's a mouthful. We often just call it Tego. It inhibits the immune system, and I don't call it an immunosuppressant drug, and I'll tell you why in a couple of slides. It's more of an immune modulatory drug, and that's because it doesn't really cause the death of immune cells, but it blocks the way they communicate with one another. So it is a slightly different mechanism. Our goal is to try to replace some of the medications that have been the cornerstones of transplant rejection for decades, mainly the CNIs or tacrolimus, which has a lot of toxicities associated with both short-term and long-term, and I'll present some of that data as well. And that's because the mechanism of action of those drugs is very different than antibody biologics. Our drug hits a very specific protein on the cell surface of immune cells when they're activated. Most other immunosuppressant medications target intracellular signaling pathways in immune cells that actually kill them. So the mechanism of actions are actually quite different between the two, and I'll spend a little bit more time on that. So our goal really is to replace tacrolimus as the cornerstone immunosuppressant across all transplant types: kidney, islet cell, liver, lung, organ type, cell type. I'll show you a little bit of data on islet cell transplant as well. as well as whether it's an allograft transplant, human to human, or we're also working in xenograft transplant, which is when people use organs from other species. In this case, the most popular one nowadays is from genetically modified pigs. We often talk about EGFR in our clinical studies, and I'll show you our bestow data. It kind of falls into 3 buckets, and all of the data is on our corporate website. I didn't want to put it all in here today because it would be a little bit too long, but you can go and find it on our website. We kind of bucketed the trial into 3 endpoints from 10,000 feet. How well did we do in kidney function? How well did we do in what's called the composite endpoint that we use to judge how well we're doing for a patient, which is patient survival, graft survival, and the rate of biopsy-proven rejection. And then obviously, as I've alluded to, the 3rd bucket was really safety. How did we compare against the tacrolimus regimen for safety? So as I mentioned, what does our drug do? It blocks a specific protein on the cell surface of T cells called CD40 ligand. I'm not going to go into 30 years of biology on it. It's too complicated, and it really doesn't matter. But as people have alluded to today, your immune systems are evolutionarily designed over millions of years to recognize anything that's not you. So when you get a cold, it takes a while for the cold to go away. Your immune system needs to recognize that something inside of you is not you, and it's done by these types of cells talking to each other. And there's more than just 2 cells, but I'll focus on T cells and B cells. It's an amplified response. These cells will take pieces of things that are not you and present them on their cell surface, and then they bump into each other in your blood, and they amplify that response. If they don't like something, they start replicating themselves so that they can talk to more and more of their friends, and that's why over the course of a few days, your cold will go away. If you think about that in the context of transplant rejection, you're taking a big piece of tissue that's not you, with millions and millions of proteins sitting on the surfaces of those cells. And if you put that in your body without suppressing your immune system, it'll reject it in a day. In the case of xenograft, you can go online and look at videos. When you take a pig organ and put it into a person, even with fairly potent immunosuppression, the organ turns black in minutes and dies. So you have to keep your immune system at bay and not recognizing the organ as foreign. And that's what our antibody does. It blocks the most critical cell surface receptor on T cells so that it doesn't go and tell its friends that it has seen something that's not you. Obviously, we've talked a lot about it today. This is really the cornerstone of preventing an organ from rejecting. You have to get your immune system to not recognizing the organ as foreign. And in the context of the first transplant that was mentioned, it was with identical twins. It took almost no immunosuppression to make that happen. In the context on the opposite end of the spectrum, xenotransplantation with a pig organ into a human takes a lot more immunosuppression than people are on with an allograft transplant. It's very hard to protect those organs. So our drug could work in almost any type of autoimmune indication you can think of. It could work in multiple sclerosis, rheumatoid arthritis, psoriasis, anywhere where the immune system is attacking an organ. There's animal data that blocking this target with tegoprubart could function. So why did we focus on transplant? I will capture that in this one slide here. It's a very simple slide. Days are on the x-axis. Percent survival of animals is on the y-axis. These are monotherapy arms. Most of you are on 3 or 4 different types of medications to prevent your organ from rejecting. These were animal studies where there were monotherapy arms, one drug. You can see untreated animals, as I mentioned, lose their organs and die in almost a day. TAC as monotherapy in non-human primates and monkeys does not do very good. It's not a good drug to prevent rejection by itself. It requires help, and there's lots of mechanisms on why that's true. There's 2 other molecules up there. One's called belatacept, and the other one is called an anti-CD40 receptor antibodies. They're different cell surface proteins on those cells where our protein and antibody hits. You can see they don't do quite as well as CD40 ligand. And the reason for that is CD40 ligand affects both of those cell populations that I had on that previous slide. It inhibits both T cell activation, which causes early cellular rejection for the most part, but it also has a very profound effect on B cell activities and B cell maturation so that you don't make antibodies against the transplant. So it's good in both cellular-mediated rejection as well as antibody-mediated rejection. So blocking CD40 ligand today has been the most potent way to prevent rejection in mice, rats, baboons, rhesus macaques, other types of monkey species, and hopefully humans. So why is this important and what are we trying to solve for? Here's some of the serious side effects that we see with CNIs, including induction of new onset diabetes in 20 to 30% of patients. Many patients experience debilitating tremors, brain fog, and other neurological symptoms. There's issues with infections and hypertension. And obviously the whole goal of transplant, and the word tolerance was thrown out today, that's kind of the holy grail of transplant, where you could be on immunosuppression maybe for a brief period of time and then wean off and not be on any immunosuppression at some point in time. I don't honestly think we're there yet, but the whole goal is to develop better immunosuppressive regimens so that you can extend the survival of organs. It was mentioned already today that in about 5 years, 10 years, about half the organs are no longer viable. We need to stretch that out to 10, 20, 30 years in order to shorten the transplant list. So we're trying to break this cycle that's been discussed today. You're on the transplant list for an incredibly long time. You get your organ, it does well for some period of time, but many people in the room that we've seen here today are in their 20s, 30s, maybe younger. They're going to need more than one organ in their lifetime with current standard of care, and the whole goal is to solve for this with new immunosuppressive drugs. Just a quick talk about kidney function, which has been mentioned, but if you look at the right-hand slide here, this is from a registry database of about 5,000 people. You can see the red line is tacrolimus. That's your kidney function as measured by eGFR over time in this patient population, which is fairly large. There's other ones that are larger, and you can see that kidney function declines over time on tacrolimus, and that's because there's nephrotoxicity associated with the drug. It's not necessarily immediate, but it accumulates over time, and that results in complications that need to be dealt with. The blue line out of this repository is a non-CNI-based immunosuppressive regimen. It contained one of two drugs, but no tacrolimus. It was either belatacept or mTOR inhibitors. And you can see kidney function in the absence of CNI is easier to maintain, if you will. So this is my very simplistic schematic of our BESTOW study, and Corey in the back is probably having a heart attack. If you go to our corporate deck, it gives a lot of details about how this trial was designed, but I wanted this to be stupid simple. Very easily, 120 people, randomized 1-to-1. Half of the patients got tacrolimus, half of the patients got tegoprubart with no tacrolimus. The rest of the immunosuppression was pretty much the same. I'm using that word loosely because every site does it a little bit differently, but we let them manage the patients the way they would. Patients enrolled in the study. It was a fairly global study, US, Canada, Australia, several countries in Europe and South America, so a pretty diverse network of sites. The endpoint was at 12 months. And again, I mentioned what they were. It was what we call a superiority design. We thought we would have better kidney function as measured by eGFR at 12 months compared to TAC. That was our first endpoint. The secondary endpoints were around that composite that I mentioned. Was it balanced patient survival, balanced graft survival, and what was the rejection rates, the acute rejection rates in the two arms? And then the last one was all of the safety signals. Not just the ones around tacrolimus, but we did focus on those as special interest side effects because we want to be better. We want to have a better safety profile. So again, I'm not going to include all of the data in this presentation, but it's all on our website if you want to go look at it. So this was our first primary endpoint. It's the entire patient population. As you can see, about 50 people went to 12 months in the tego arm, 56 in the TAC arm, and you can see the eGFRs there are pretty close. Tegoprubart was 69, and tacrolimus was 66. We missed our primary endpoint in this study, which was really disappointing to us last week. We presented this data last week, and the data is only 2 weeks old, so you're kind of seeing it hot off the presses as well. This surprised us a lot, not because our drug didn't perform. This is actually some of the best kidney function that's ever been seen in a clinical trial, period. And eGFR is the best predictor of long-term kidney survival. So this was a really exciting result for us. What surprised us is how well TAC did. In historical studies, tacrolimus is typically in the 50s. We kind of understand why this happened, and it's not unusual in a clinical setting. These patients got exquisite care. And when I say exquisite, I mean the TAC patients were in the clinic almost every day of the week for our entire study. They were managing the trough levels of TAC in the study daily. The other thing that we noticed, in the protocol, we put specific language in that if serum creatinines went up, which is usually a potential sign of rejection, in addition to cell-free DNA, we should have probably put that in too, but we didn't. They were supposed to biopsy. They biopsied in the Tego arm like nobody's business in our study. And in the TAC arm, they didn't biopsy. Instead, they bumped the TAC levels up. When the serum creatinines went back down, they pushed the tacrolimus back down to trough. So they were actually treating rejection without biopsying. And we know that's true because we had protocol biopsies at 12 months, and we picked up a lot of biopsies in the TAC arm that weren't otherwise reported. So the EGFR data, we did a few other things post-analyses that was part of our statistical analysis plan. We separated living and deceased donor. You can see that Tego did much, much better compared to tacrolimus in living donors, about a 10-point difference. Interestingly, the deceased donors were the same, and that's probably why we didn't hit our endpoint. And that was a little bit puzzling to us, so we broke this down a little bit further, and we broke it down by KDPI, which is an indication of the quality of the organ. And you can see, which is really interesting, again, we won against KDPIs with what we would call poorer quality kidneys, I guess, less than 35, greater than 35 rather. For KDPIs less than 35, we're about the same again. But there's one really interesting piece of data on that left-hand, the right-hand graph that I'll flip back and forth. Look at the tacrolimus score of EGFR in this population. It's 80. It's actually better than what TAC did with living donors, and those are good kidneys. So there's something going on with stratification in our deceased donor population across these sites, and we're starting to dive into that a little bit more. But we have to kind of figure that one out because we're obviously going to be planning for phase 3 next. I'm not going to talk about the composite endpoint here. I left it out because we probably don't have enough time, and I wanted to get to safety. There was 1 death in each arm. There was 1 graft loss in each arm. We had a slightly higher incidence of BPAR that was higher than standard of care, which is not unusual for our drug class. Belatacept also has that same phenomena, but the rejections were very, very treatable. The patients that stayed on Tego had EGFR 70s. The patients that unfortunately post-rejection switched over to TAC were in the 50s. So, and we've been learning that for a while with our drug. We saw that in our phase 1 study too. So our messaging has been, if you see rejection on Tego, stay the course, even though it's scary. Stay on drug and your kidney function is going to be better. But here's the safety data. This is what I would call the grand slam home run. Anything on the right that's in green had a higher incidence in the tacrolimus arm. The one in red, which is proteinuria, was higher in the Tego arm. The Tego arm had a lot more proteinuria because there was a little bit of an imbalance in the amount of underlying autoimmune disease that was correlated with our enrollment, and a lot of them had reoccurring FSGS that led to higher proteinuria in the Tego arm. So that was probably an enrollment imbalance. But look at the amount of new onset diabetes we saw in the TAC arm. Look at the percentage of patients that experienced tremors, brain fog, hypertension. All of these things are common things that are associated with CNI exposure in patients that are on tacrolimus, and even at 12 months, that signal came up very, very clear in our study. And then I think there's about 8 safety table slides in our presentation, our corporate one. I threw in this one just to again show the differences in the hypertension and cardiac. There was actually a significant signal in cardiac death as well as a hypertensive crisis in our study. So I'm going to take 2 seconds and switch over to our other indication because this data is absolutely fabulous in my mind. It's actually miraculous. Islet cell transplant. Other than pancreas transplant, you can actually take the pancreas from a donor, isolate the islet cells, and surgically put that through the portal vein of the recipient as an islet cell transplant to replace for people with type 1 diabetes that can no longer control glucose levels and have been on exogenous insulin for a very long period of time. We're focusing on a very subset or small percentage of people with type 1 diabetes that have severe hypoglycemic unawareness events that leads to a lot of comorbidities. And we're doing this as an investigator-initiated trial in Chicago. So I just wanted to show you one patient. We've done 6, but they all look pretty much like this. Really sick people, very high HbA1cs, more than 2 or 3 hypoglycemic unawareness events per year. And this is what their HbA1cs did post-islet cell transplant. You can see it went from an 8.5 after the first transplant in a 30-year-old female that weighed about 50 kgs. She was on exogenous insulin for over 20 years, and her daily insulin use went down to 0 within 1 month post-transplant, and she's now out past a year. We've now done 6 people with type 1 diabetes in Chicago, and all of them got off exogenous insulin within 6 weeks post-transplant, leading to what really you could describe almost as a functional cure for their diabetes. Our drug is really good at protecting these cells, because one of the problems with islet cell transplant, it's not been very well adopted, because in order to protect cells historically, the patients have to be on tacrolimus, and tacrolimus is toxic to the cells that you're transplanting. So most people aren't going to swap their diabetes for all of the toxicities that are associated with CNI. So we're very excited about the data we have thus far in our islet cell population. So where are we going from here with all of this data? We'll take our phase 2 kidney data that I just presented and go to the agency probably in the first quarter of next year and lay down plans for a pivotal phase 3 study. We're also going to transition that islet cell study from an investigator-initiated study to a phase 1/2 sponsored study that we've already engaged with the agency over. And our goal is to basically continue to expand tegoprubart into other types of transplant. We have enough preclinical data at this point in monkeys to go into liver transplant, and we've been supporting pretty much all of the xenotransplant experiments that have been going on in humans. And thank you for your time.
Just a question. In the phase 2 trial, the BESTOW trial, was the induction therapy the same, even though it was an international trial? Was it all using thymoglobulin, or did you have other induction therapies?
So it was all induction with ATG thymo, and we did that because there is some data with belatacept that other induction therapies like basiliximab that don't control T cell responses quite as good as ATG has a lot higher rejection rate. So ATG was used in all of the countries.
Thank you.
Any other questions?
Question? Yep. Dom?
In comparison to the Tacro, what's the schedule? Is it also twice a day med? Is it extended release? And what's the window for like lab draw?
So it's a biologic, it's not oral. It's an IV infusion, and it's done once every 3 weeks, and it takes about an hour. We have a sub-Q formulation that we'll probably bring into the clinic, probably not next year, or maybe next year or the year after, and we'll probably start out with an islet cell first before kidney, but the sub-Q you would do at home. But it's a 1 hour infusion every 3 weeks right now.
So for when the labs get drawn, a biological med, does that mean that it could be drawn, like from the moment that it's infused, so however long it lasts, how do you determine those numbers, the concentration of it in the body?
So in a clinical study, we see our patients more, you come into the clinic every 3 weeks for an infusion, and that's it. Unless you're not doing well, unless we've seen a sign of rejection or something else, once you're done your ATG induction, you're gonna be on our drug, MMF, in some cases probably a 5 mg dose of prednisone, but other than that, you don't have to come into the clinic except for your infusions every 3 weeks, because that's the half-life of the drug.
They don't do levels like Tacro.
Not at all, okay. So then its success is measured by
Creatinine, renal
creatinine?
function,
Okay, thank you.
GFR.
A question from the audience online. Could this potentially be applicable for other transplants,
This drug can
such as
be-
heart and lung?
Yes, absolutely. There's plenty of data in liver. We've done a cardiac xeno, supported one of the cardiac xenos. It can be used for any type of transplant, cells, organs, human or xenograft.
Thank you. I think we've heard from the panel here the innovation in expanding the pool, in leveraging a condition that is quite common to increase the pool of organs. We've heard about how we can potentially be more scientific when we look at rejection and find rejection earlier. And we have finally heard about this potential for a new medicine that could reduce the side effects, but also extend the life of the graft, which we're all very focused on and very much hoping for, right? That concept of one kidney or one transplant for life. And I think it's also important to point out for other individuals who are not kidney transplant recipients, but are other organ transplants, that one of the horrible consequences of the current medication is that you might actually be in kidney failure because of the medication that we are on right now. Tacrolimus does lead to kidney damage and pancreas damage or beta cell damage. So those with heart transplants often, sadly enough, need a kidney transplant after a number of years. So it really is in all of our best interest to try to improve these drugs. And I think it's really important to raise the patient voice for that, as well as being a little bit more scientific when it comes to our potential rejection risk. So having technology that could analyze that earlier versus having to go in for biopsy is really important. So thank you for that.